Yeah, my name is John Nolan. I'm one of the joint replacement surgeons at Mercer-Bucks Orthopaedics, and I'm going to be talking about the diagnosis and treatment of hip pain. So the first thing is, well, where is the hip exactly? So if you ask a lay person that, a lot of times they'll put their hand on the side of their, what they call their hip, which is up in here. They may point to the outside point of their hip. They might point to their groin area. So the word hip from a layman's term doesn't necessarily match up with what we're talking about when we're talking about the hip. And this is an x-ray of a pelvis. And again, just to put it in perspective, when you put your hand on your side, what you would say is your hip, you're actually up here on the top of the iliac crest, which is the pelvis. If you have pain in the like symphysis pubis area, that's in here, and the actual anatomic hip, what we refer to as the hip, is this joint here between the top of the femur and the ball of the pelvis, which is called the acetabulum. So a substantial percentage, probably 75% of the people that come to see me for hip pain do not have hip pain. They have something else that they're thinking is hip pain. First, there are non-orthopedic medical conditions that can mimic hip pain, problems with your kidney, a hernia, sometimes a diabetic neuropathy, and in women, pelvic issues can all cause pain in an area that can be confused with hip pain. Likewise, there are problems that are orthopedic related but aren't specifically the hip joint, bursitis. You can have symptoms from the sacroiliac joint, which is where the pelvis and the spine meet, or you can have sciatica, which is from the back where the nerve is being pinched and causes pain into the buttocks and sometimes down the leg, that people frequently think of as being hip pain. So one of the conditions that we see that people frequently think of as hip pain is inflammation of the sacroiliac joint. This is where the pelvis meets the spine right here, okay? And there's a lot of force there because it's basically anchoring the upper part of your body to the pelvis. And you can have pain in that area, which is just a little bit to the outside of where your spine is, or it can radiate into the area of the buttocks, occasionally down the leg. And it's a frequent cause of hip pain. Another cause of hip pain, which is fairly newly understood, a lot of athletes get this, called a sports hernia. Basically, the muscles that keep your abdominal muscles toned, the abdominal obliques, these muscles in here, insert into the bone on the top ring of your pelvis. And it can be not sports related, but you can basically get an avulsion of the muscle. It's called a sports hernia, and it's fairly common in sports, soccer, football, and it's something that may require surgical repair, but again, isn't strictly speaking a hip problem per se. The treatment for the sacroiliitis, the thing that I put on the slide last, is generally speaking a combination of activity modification, meaning rest, sometimes some anti-inflammatory medication, and sometimes injection, almost never a surgical treatment. A sports hernia, again, the initial treatment for almost everything we treat initially starts with the basics. Modify our activity for a period of time, a little bit of stretching, physical therapy, some Tylenol or Advil or anti-inflammatory medication. And a lot of these problems will get better on their own. Obviously, in the case of a sports hernia, if it's symptomatic enough, and again, this is not something an orthopedist would fix, but a general surgeon, they basically take the muscle and sew it back into the bone. Another common cause of hip pain is a trochanteric bursitis. There, the pain is on the outside part of the hip. So here's the femur where it goes into the acetabulum. That pain is lateral. It's kind of where you put your hand in your pocket. It can be excruciating. Generally, you get pain with getting out of a chair. You might get pain when you're twisting or turning your leg. When you're examining somebody, you get tenderness right over the outside part of the hip. It can be a tendonitis or a bursitis of the inflammation of the bursa. And again, the treatments, and I'm going to say this a number of times because it's the same for just about everything. Again, activity modification, meaning if you're running 10 miles a day, maybe you don't run 10 miles a day for a couple weeks. Physical therapy, some stretching exercises, anti-inflammatory medication if you can tolerate that. And then it's an area where there's a bursa. You can sometimes do injections of corticosteroids in there infrequently to try to cut down the inflammation. And this is something that can be very painful, generally responds to conservative treatment. In the last 32 years, I think I've operated on 2 people for this problem. So it's really not a surgical problem. And it's nice because most of the reasons that people come to see us for hip pain, and a lot of times they think they're going to need a hip replacement or something like that, get better with some very simple non-surgical treatment. So then there are people that have pain and have like a painful snapping in their hip. Sometimes it just occurs out of nowhere. Sometimes they're actually able to reproduce it. And that can happen for a couple of reasons. 2 reasons. Iliopsoas tendinitis, that's the main hip flexor. It's the muscle that's in the front of your hip that allows you to bring your knee up. And as you rotate your leg, it can snap back and forth. Treatment again for that is generally a combination of anti-inflammatory medication and occasionally an injection. And rarely, if it's symptomatic enough, you would go in there and surgically release the tendon to stop the snapping. Another cause of a snapping hip is actually a tear of the cartilage inside the hip joint. Again, this is something that is more often than not in patients that are younger. The outer rim of the hip has a layer of cartilage that provides additional security for the hip so it doesn't pop out of place. Any type of an injury can cause that to tear. It can cause pain, generally in the groin area. And if it's a big enough tear, it can cause snapping or popping of the hip. Again, either of those, you're going to have pain right in this anterior area of your groin. Again, the initial treatment is going to be the same. Your symptoms are going to be pain and snapping and occasionally instability or giving way. The treatment, again, injections, physical therapy, anti-inflammatory medication. And in the case of a labral tear, oftentimes, if it's not made better by those measures, you can go in surgically, either arthroscopically or through a small incision, and smooth out the part of the cartilage that's torn or surgically repair it. In order to distinguish between some of these problems, because we can't always tell on the basis of physical examination, there are certain tests that we have to do. And the gold standard for that is what's called an MR arthrogram. It's an MRI that's done after somebody injects, after a radiologist injects dye into the hip. This is a picture of a needle going into the hip. And this is a picture of an MRI that's done afterwards. And you can see all this dye here. And up here where there's an arrow, you can see there's a tear in this labrum. And that can cause pain, it can cause snapping. That's the definitive way of treating that, of diagnosing that. Our ability to pick it up on physical examination, probably not much better than 50-50. And again, this is what you do when you look inside the hip joint. You see a piece of ligament that's torn, a labrum that's torn off the acetabulum. And depending on the size of the tear, depending on the patient's circumstances, that would either be surgically repaired or just smoothed out and cleaned up. This is a picture of another picture of a labral tear. And again, this can be surgically repaired or just smoothed out. And what you do about that is generally determined by the patient's circumstances. Your treatment for a 25-year-old, shortstop is going to be different than your treatment for a 60-year-old who just has some intermittent pain. This is one of the more common causes of snapping from the hip joint itself. There's also something called impingement, where you get a little bit of bone growing around the hip. So you have either what's called a pincer lesion, where a little bit of bone on the acetabulum is kind of growing over the covering of the hip, or you've got some overgrowth in the femoral neck, and either of these can cause a mechanical impingement, which causes a snapping, or it can cause limited range of motion or pain. And in the appropriate person, these are generally younger patients. These can be treated, if they don't get better with physical therapy, by going in and surgically just removing a little bit of the bone here or a little bit of the bone here to allow you to get back to normal activities. And this is something that a fair number of athletes, for instance, have done. This is a picture of, again, the pincer lesion. You can see how it kind of comes down here. And the treatment is just to go in and just remove some of the bone so that this is not banging against this. And that'll give you an improved range of motion. Another fairly common cause of hip pain is something called avascular necrosis. Basically, the blood supply to the ball of the femur is limited in that it only comes in from one side because the rest of the hip is made of cartilage. So whenever you have that, basically you're at risk for that blood supply being compromised and the area that it serves basically becoming ischemic and dying. Think of it as being like a heart attack of the hip. This is a diagram here where a given portion of the femoral head became ischemic. The bone tends to get soft, it dies, and then it collapses and goes on ultimately to form arthritis. Why does it occur? It can occur as a result of an injury. It can occur as a result of the use of steroids. It's one of the complications of excessive alcohol use. It can occur as a result of Caisson's disease, which is basically the bends. It's if you don't decompress adequately when you're diving, scuba diving. And most of the time it's called idiopathic, which basically means we don't know why it occurs. But it's a fairly common cause of arthritis in people who are younger. And the treatment, you can diagnose it on X-ray. This is a normal hip X-ray right here. The ball is nice and round, nice clear space. Here, the ball is like being flattened because the head is kind of died. It's become softer and it's collapsing. Sometimes when you see people early on, they have pain. The X-ray still looks normal. The test is to make that diagnosis is an MRI. And you can see actually this person has it on both sides, but there's a large area of the femoral head here that's ischemic and is dying. Again, the treatment depends on largely the age of the patient. This will not get better by itself. This will go on to collapse almost 100% of the time if not treated. In younger patients, if you get them before the bone collapses, you can do what's called a core decompression, where you basically drill a hole from the side of the hip into the bone, into the dead area. And what happens is the blood supply from other parts of the hip will go in there and it may revascularize. It's an operation that probably has a 50% success rate, which isn't really very good, except it's the best we have, short of doing a hip replacement. And if you have this condition in somebody who's in their 20s or their 30s, it's worth doing an operation that has a 50% success rate to try to prevent somebody from needing a hip replacement at that kind of age. Basically, after you do the drilling, you need to keep people off the hip on crutches or a walker for about 6 weeks, and then another month or so before they can go back to athletic activity. And again, the success rate may be 50%, depending on how much of the hip is involved in the first place. And again, this is the definitive treatment for that. This is a picture of somebody with a hip replacement. And then another cause of hip pain is a fractured hip. Now, obviously, if you have a significant fractured hip, you're going to know that right away. There are people that fall and can't get off the ground. They may have a deformity of the leg. They're the people that go into the emergency room and get picked up right away. But it is possible in people who are either older or in athletes who are overactive to develop either a hairline fracture of the femoral neck or a stress fracture. That would be something that would occur in runners. So one of the conditions that we need to be concerned about in somebody who decides to take up training for the marathon or does a lot more running, they start to get weight-bearing hip pain with x-rays that are either minimally abnormal or show a little line is a stress fracture of the hip. And that can be treated if it's picked up early enough by putting a couple pins in there and limiting your activity. If it isn't picked up early, this thing will basically, the ball of the head will come off, and then you need to do, again, the equivalent of a hip replacement. And then finally, the main focus of this talk is on hip arthritis. Basically, what hip arthritis is, it's inflammation of the hip joint, but it's really, think of taking the bottom of a chicken bone, the shiny part, and sanding it down with some sandpaper. And basically what you have is bone rubbing against bone in the hip. So you'll get stiffness, you'll get pain. This is a picture of an x-ray of a pelvis. And on the left, on the right, which is my left, your left, you have a fairly normal hip x-ray with nice round surfaces and a nice symmetric clear space in between. This is a normal hip x-ray. This is somebody who has severe hip arthritis, almost no cartilage in there, bone spurs. This whiteness is called sclerosis. So this is somebody who's not going to have very much motion in their hip. They're going to be walking with a limp. Again, these are some of the findings of hip arthritis. Here you've got the joint space. Here you don't have one. You've got these bone cysts and bone spurs. So hip arthritis, unless it's very, very mild, can be picked up on a plain x-ray. The severity of the symptoms don't always correlate with the amount of arthritis on the x-ray. So surprisingly, there are a lot of people that come into our office with x-rays that look like this that aren't really having that much pain. And if that's the case, they really don't need much treatment. Other people have more pain and don't have as much arthritis. So that's the way it is with a lot of things in medicine. Again, the symptoms for hip arthritis, painful gait, you walk with a limp, and decreased range of motion. One of the earliest findings I find that people notice is that they have difficulty tying their shoe because they can't rotate their hip to get their right leg up on their left knee to do it. And again, if that's their only problem, they probably don't need much in the way of treatment, but that's an early finding in somebody that has hip arthritis. Again, initial treatment, rest, weight loss, for the most part, is good for everything. Again, we're not talking about weighing 110 pounds here, but if your BMI is 40 or 50 and you're 100 pounds or 50 pounds overweight, taking the weight off will substantially limit your symptoms. It doesn't mean you can't get, it doesn't necessarily mean you'll get rid of the symptoms entirely, but it may make them more bearable. It also makes it easier to treat surgically if it comes to that. Anti-inflammatory medication, again, physical therapy, probably not as helpful as it is with knee arthritis, but it's generally worth sending a person to a physical therapist once or twice to just review some exercises. And then there's some of the other minor surgical options. Again, first thing people generally do, and they figure this out all by themselves, if it hurts when you walk, you get a cane. Generally speaking, you use the cane in the opposite side of the hip arthritis, because the idea is that you're shifting your weight off of the affected hip. So if we don't tell people that, they oftentimes will figure that out by themselves. And if you have mild hip arthritis that only hurts when you go for long walks, this may be an option for treating you. Again, weight loss. You don't have to be super thin, but if you are substantially overweight, that's not only a risk factor in having symptoms of hip arthritis, but it's also important in treating the symptoms. And if it comes to surgery, there are actually parameters now that we are essentially being told to use by the insurance companies and government agencies, that if you're above a certain parameter, a BMI of 40 is what most people use, the risks of doing the surgery are such that it's not recommended. So a general rule of thumb, if you have a BMI is a function of your height and your weight. And if your BMI top normal is 25, 30 is considered obese. If your BMI is substantially above 30, you really need to work on getting that weight down, both for symptom release and also to help yourself out with treatment down the road. Again, medication, non-steroidal anti-inflammatory medication, either over the counter like Advil or Aleve, or prescription. There's about 15 different ones, or Tylenol. Now, the anti-inflammatories probably more effective for arthritis. And there was a time, probably up until a couple of years ago, when we used to give it out like candy. I think that we're a little more hesitant to do that now because there's been a growing recognition of the side effects of the medication, potential for kidney problems if you take it for long periods of time, the potential for ulcers or GI problems. And obviously, if you're on a blood thinner, you're not really able to take it very often. So these drugs can work wonders. And for short periods of time, they're great. For long periods of time, it's a cost-benefit analysis. So you really need to discuss it. And obviously, with whoever's treating your arthritis, your orthopedist or your rheumatologist, and also your medical doctor. Some doctors feel very strongly that if you have hypertension, you shouldn't be taking these kind of medications. So there are some supplements. One is, most of them are variations of glucosamine and chondroitin sulfate. We started to see these maybe around 2000. They started to come out. Big bursts of popularity. They did some double-blind studies. The bottom line is they work very well in dogs. If your dog has hip arthritis, the vet will probably prescribe this. There's no evidence that they work well in people. So when we say that, what we mean is that the way they test out drugs or vitamins is they do a large double-blind study to try to factor out what the placebo effect is, and they figure out whether a medicine or a supplement is more effective than placebo, which is like a sugar pill. So having said that, that doesn't mean that there may not be some people who it helps. So I generally tell people that at the very least, you might be wasting your money, but if you try it and you think it works, no harm done, but there's no scientific evidence that it works. Certainly you don't need to pay a premium for it. Then there's some of what are called Ortho Biologics. PRP, which is plasma-rich protein, and stem cells. These are very new. They are marketed very heavily by certain practices. The role of these types of treatments in general in orthopedics is, to put it charitably, unclear. Presently, the position of the American of Orthopedic Surgery is that there's no evidence that they're either safe or effective. Now, they probably have some future use, and we just haven't figured out what that use is, what patients will benefit and what patients won't. It's not covered by any insurance, generally tends to be expensive. I've seen people charged $10,000 for injections of stem cells. It's not FDA approved. So recognize that when you see an advertisement on the web or on television or whatever for this type of thing. Do I think it's dangerous? No, I don't. Do I think it's effective? There probably is a role for it. And in our practice, we do have a capacity to use it, and we do occasionally use it. And we don't do it at a huge markup, but I mean, you realize you're trying something that's untried, it's not a proven cure at this point in time. So the role of these orthobiologics is still to be found out. The holy grail of orthopedics is to get something that you can put in a joint and get it to grow cartilage. That's where this is going. And unfortunately, we're not there yet. And we're not probably close to being there yet. So it's a possibility that there's a limited role for this. Certainly no evidence that it's effective for somebody who otherwise would be getting a hip or knee replacement. So the definitive treatment for hip arthritis is a hip replacement if you failed conservative non-surgical treatment. What a hip replacement is basically remove the ball of the hip and you put a metal stem down the femur. Unfortunately for us, the femur is hollow, it's like a pipe. You then put a metal ball and then you put a cup, a metal or ceramic cup on it. And all hip replacements, since the operation was approved back in, I guess it would be in the 1968 or 69 when the FDA approved it in the United States, are basically variations of the same thing. You make an incision, you remove the femoral head, you resurface the acetabulum, you replace the femoral head. So whatever marketing you see about some new improvement, Every total hip replacement is done. That's basically what they're doing. There have been a lot of improvements over the years. The basic operation from the standpoint of the surgeon is basically the same. But there have been a lot of advances which have changed the experience from the standpoint of the patient. So when I was a resident, and that was, I finished in 1988, the DRG, which is the number of days that Medicare will pay a hospital to keep a total hip patient in, was like 21 days. And now Medicare thinks you need to leave the same day. Well, they were a little bit off then. They're probably pushing the mark now. These can be done as outpatients. We do them as outpatients. Probably not everybody is a good candidate, but certainly most patients, overnight stay, the percentage of people that go to rehabilitation facilities, which used to be 40, 50% 10 years ago, probably 5% now. So again, the recovery time, the length of stay, the pain control has gotten dramatically better. The longevity of the implants, much better than it was. We used to say when I finished it, they might last 5 or 10 years. Now we like to think that they'll last between 25 and 30 years. So for that reason, the age of the people that we can put them in has gone both down and up. We can put it in younger people because they'll last longer. And because of the surgery is less involved, we can put it in older people who may not have been good candidates 15, 20 years ago. And the activity levels that we'll accept are higher than they were at one point in time, although you still need to have realistic expectations in terms of what you can do. So talking about some of the, I don't say controversies, but so you're going to have a hip replacement. What are the options? What are the things that are different? So there are different types of material. And the first thing we talk about is the interface between the ball and the cup. The ball is going to either be metal or ceramic. There's some evidence that ceramic may last a little bit longer. And for that reason, in younger patients, we tend to use it. It's a minimal difference, and there's an expense involved. So in older patients, we generally don't, there's no reason to. The lining of the cup is generally polyethylene, which is a fancy plastic. And in the last, I think sometime around 2006 or 7, when the last time they made substantial advances in the polyethylene, we used to have to worry considerably about the wear of that plastic, causing loosening of the hip. But now the plastic lasts really well, and so that problem has gone away for the most part. And then there was metal and metal. This is something we inherited from the Europeans, probably in the mid-2000s, by using a metal, meaning a metal cup and a metal liner, a metal head. You can make a bigger head that would give you better range of motion. It worked really well a lot of the time. Unfortunately, when it doesn't work out well, it causes problems. The metal can get absorbed. So sometime in the 2011, 12, they realized this was a problem. Nobody does this anymore. Occasionally, we have to go and take one out because the metal ions can be absorbed by the body and can cause problems with internal organs, the heart, and things like that. This is an example of why, and this is my personal opinion, you may not want to be the first guy on the block to get a new product. Sometimes things look like they're really great ideas until they look into it a little bit and they're not. Now, it is true that these things have to be tested by the FDA, but you know, they test them for a couple of years. That doesn't tell you what it's going to be like in 15, 20 years. So if something's right out of the market, again, it depends on what the alternative is. If there's a brand new drug that treats a type of cancer that you have, you may want to take that because your alternative is not to live. If there's a brand new type of hip replacement and the alternative is one that was probably going to last 25 or 30 years, you have to think, do I really want to be the first guy to use that? Again, these are the bearing surfaces. They almost all have metal lining in the back. And this is a polyethylene, this is the plastic, and then this is a metal titanium stem. And then you can either have a ceramic or a cobalt chrome head, and there's one company that puts a cobalt with a oxinium, which is just a lining on the head. So these will all work fine for 25, 30 years and are rarely a problem. So the standard of care, basically, the average person that gets a hip replacement gets a metal head articulating with a polyethylene or plastic back cup. So when the implant was initially approved by the FDA in 1969, it was brought in from England. Actually, a guy named Charnley developed this cement, which we used for a long time. So we cemented the hip in, the stem in, and the cup actually. And that was the gold standard for a long time. And it works pretty well. And actually looking back at some of the ones that were done 40 years ago, they don't hold up bad. But the problem with the cement is you put it in and it's as strong as it's ever going to be the day you put it in. And then it loosens over time. And sometimes the body sees a little bit of the cement debris and it attacks it because it recognizes as being a foreign body. And in doing so, it kind of eats away at the bone and can cause loosening. And this is how the cement works. You've got the implant, you've got the bone, and you've got this layer of, it's actually not it's actually a grouting agent. It goes in there and it hardens and fixes the implant in place. We still do this in older patients for economic reasons. And also if somebody has very thin bone, osteoporotic bone, like for hip fractures, a lot of people will do it because it's more secure. And again, if you're operating on an 88-year-old with a hip fracture or if you're hip arthritis, probably don't need to worry about the 25-year survival rate as much. So sometime in the late 1980s, they developed the technology where there's metal beads on the outside of the implant and the bone actually grows into the implant so that it gets stronger with time. And this is really becoming the standard. This is a picture of a patient of mine I did a few months ago. You've got a metal implant, press fit in there, the acetabulum press fit in, the bone basically grows into that. That's become the standard of implant. It gets stronger with time rather than looser with time. And it's been a tremendous improvement in technology. So one of the other things that you'll hear, if you're looking into having a hip replacement as well, do you do the anterior approach, do you do the posterior approach? So most surgeons up until about 10 years ago routinely did the posterior approach. In the old days, they used to do the anterior approach. And then in the real old days, when John Charnley was doing them, and some guys still do it, they do a lateral approach. So there's 3 ways of doing it. There's even modifications on that. And about 10 years ago, there was a big push by some surgeons to push the anterior approach, saying, oh, it's simpler, we don't cut the muscles, the recovery's faster. Well, having had 10 years to look at the data, it turns out that all 3 of these approaches have identical results in terms of long-term result, in terms of short-term result. It's basically patient and surgeon preference. The complication rate is actually slightly higher with the anterior approach. That may be a function of the learning curve. But any way you slice it, you're going in there and you're basically removing part of the bone with a saw and putting an implant in. Through the anterior approach, you get a better view of the cup and a lousy view of the stem. Through the posterior approach, you get a great view of the femur, and you have to work a little harder to get a view of the acetabulum. So again, it's surgeon preference. These lengths of these lines are just the person who did the slide. The lengths are not material. It's one of my partners does an anterior approach. He actually makes a longer incision than I do through the back. A lot of the length of the incision depends on the person who's having the surgery, how heavy they are, and things like that. Again, this is a picture of a posterior approach. You're basically going in through the side. You're splitting the muscles in line with their fibers. So you're not actually cutting anything. And then you dislocate the hip and remove the ball and put in the procedure, put in the implant. And this procedure, under ideal circumstances, is anywhere from 35 minutes to an hour, irrespective of which way you do it. And again, studies show that independent of whoever's marketing the product, and the anterior approach was initially marketed heavily by the company that sold the table that you needed to use to the anterior approach, surprisingly. But there's no difference in dislocation rates, in the amount of pain you have. It really depends on the surgeon, surgical experience, the patient, and how the actual implant goes. Minimally invasive hip and knee replacement. It's a marketing term. We do make much smaller incisions than we did 20 years ago. When I was a resident, they were 12, 15 inches long. Now I've done hip replacements through 4 or 5 inch incisions in a patient who is fairly thin. At the end of the day, there's no such thing as a minimally invasive. I tell people, if you want a minimally invasive incision, bring your minimally invasive body. If you weigh 120 pounds, we can do that surgery through a small incision than if you weigh 300 pounds, because we have less tissue to go through. And many studies have shown, this is more in the knee than the hip, that if you actually struggle to do this through too small of an incision, you end up stretching the skin and end up with a worse looking wound with a higher incidence of wound complications. So you got to make the incision about that long to get the implant in. And that's basically the deal with that. And any operation where you go in and use a saw to remove bone, I don't think is appropriately called minimally invasive. Now, a question was flashed up on the screen, what do I prefer in terms of the approach? I trained using the posterior approach. And I have done the anterior approach, and I've done the lateral with one of my partners, and I like the posterior approach. It's simple to do. I've been doing it for 30 years. It's what probably 75% of the surgeons in the country are doing. One of my former partners, who's now up at HSS, when he was here, was trained in both, and he ended up going back to the posterior approach. Again, that's surgeon preference. And if some surgeon tells you he likes to do the anterior approach, if he's doing your surgery, do the anterior approach. But the complication rates, again, statistically a little bit higher anteriorly, but it's really surgeon preference. It's how they've been trained to do it. Like I said, I get young, healthy patients out of the surgical center in 5-6 hours. One of my future patients says he needs a small incision because of his modeling career. That's good. Good to know. There is actually something called a bikini approach, but we won't talk about that now. So talking about the general concept of the surgery, the improved use of regional anesthesia. We do 95% of these under an epidural or spinal. Blocks, which is where the anesthesiologist will inject some of the nerves, and long-acting local injections have dramatically reduced the need for narcotics. There's a drug came out called Exparel about 4 or 5 years ago, which is a long-acting anesthetic. We started using it, miraculous reduction in pain. We've actually figured out how to do that with other drugs that are less expensive, that are just as effective. But the bottom line is, if you had this surgery 10 years ago, you're going to be in the hospital for a couple of days with a patient control, a PCA pump, having IV morphine injected into you for a day or two. Now I get people a prescription for 20 or 30 Percocet and maybe one refill. And it's just a whole different experience. We use a lot of other drugs as well. So the need for narcotics, and it's not just a matter of worrying about the addiction thing. It's you take those narcotics, you get constipated, you get urinary retention, you're groggy, you're higher risk of falling. So all the complications associated with that have dramatically reduced because of the decreased use of narcotics. So then a new drug, which is actually an old drug, Transimic Acid. Apparently the cardiothoracic surgeons have been using it forever, but somebody figured out to use it for hip and knee replacements. It's miraculous. It essentially eliminates bleeding during the operation. It basically keeps the clots from breaking up. There are a few patients, people who have histories of recent blood clots, where we're a little bit concerned about using it. There are guys that say you can use it anyway. Again, I'm a late guy on the curve. I'm going to wait till the data is a little bit more clear on that before I start giving it to everybody. But your standard patient that gets a total hip or total knee, we give them IV Transimic Acid. I can't remember the last time I gave a transfusion. Our transfusion rates in our hospitals are under 1%. It used to be like 30%. So way less bleeding, which is less pain, fewer transfusions, obviously, fewer risks of that. Okay, so robotic surgery. Okay, some of the hospitals that I operate on have robots. It's actually a bad term to use for what they're talking about. It really should be computer-guided navigation, and that's a little bit different. So the robots that the general surgeons use are literally, a surgeon is sitting in a chair with his hands on a machine, and he's moving controls that then move these arms and have greater degrees of rotation, things like that. And that's what I think of as a true robot. The robots that you see marketed by some of the hospitals, and I've trained on them and I do use them sometimes. Basically, it's a fancy CAT scan guided navigation system that you take circle points on the body, put those into a computer, and it kind of assists you in putting the reamer where you need to go. All of the surgery is done by the surgeon, just kind of like a guide to going where you want to go with the angles. And again, and I disagree with this, but the official position of the American Academy of Orthopaedic Surgery is that the robot's not beneficial and not cost effective. Now, as somebody who uses computer navigation system more for my knees than my hips, I would disagree with that. The navigation system that I use for my knee probably adds 5 to 6 minutes to the operation in my hands, in my opinion, makes the x-rays look better. But right now, at least, that's the official position of the Academy, and there's no solid evidence to say otherwise. So again, it gets down to surgeon preference. And if you go to somebody who uses a robot all the time, well, you want them using a robot for you, or computer navigation or whatever system that you're using. So in summary here, a combination of newer drugs, anti-inflammatory medication, IV Tylenol, surprisingly effective, tramadol, Neurontin or gabapentin, and long-acting narcotics have dramatically changed the game in terms of pain relief. Now, if you talk to people who have had hip and knee replacements, they will tell you, generally speaking, the knee replacements tend to hurt more. Not everybody. So again, we want people to use as little medication as possible. You know, I had a patient I did a knee replacement on a few months ago, who was part of this thing, who just took Tylenol afterwards. That's great. Some people can do that with the hip replacements as well. Tylenol and maybe some ibuprofen or some meloxicam. Great. If you got to use the narcotics, you want to use it for as short of time as possible and as little as possible. And we've really come a long way in that regard over the last 5 to 10 years. So let's talk about the risks of these kinds of surgeries, okay? Any operation, no matter how minor, has risks and obviously benefits. The biggest risk we worry about is the risk of infection. The risk of infection is very low. It's less than 1%. So the problem is, if you get an infection, it's a big problem. It may mean that you have to have surgery. It may mean you have to have 2 surgical procedures. If you get it early, sometimes you can wash it out and just replace the plastic liner and they'll be okay. That's very likely to be successful if you catch it early on. If you get a late infection or you don't pick it up right away, it may require actually taking the implant out for a couple of weeks and putting one back in. For that reason, we go to great lengths to lower the risk of infections. Everyone's given antibiotics. The surgical team, everyone in the room is wearing a spacesuit. The rooms have what are called positive pressure, where there's more air pressure in the room than outside the room, so everything flows outside the room. You don't have air blowing in the room. The number of people allowed in the room during the operation is kept to an absolute minimum. This is not an operation where we have 6 nursing students sitting around watching the operation, or 3 anesthesiologists. We keep it to an absolute bare minimum. The risk of dislocation, again, statistically 1 to 3%. It's in order to do the operation, you need to pop the hip out of place. Obviously, we don't want you doing that after the operation. Depending on which approach you use, it may dislocate out the front of the back, and depending on how stable the implant is, we may put you in certain restrictions for a period of time. If you do have a dislocation, it usually means you have to go back to the hospital. We have to pop it back in a small percentage of cases. If it continues to pop out, there may need to be another surgical procedure. Either your muscles aren't tight enough, or in the process of putting in the implant, the orientation of the implants wasn't exactly right and has to be reoriented. Loosening, again, that was a bigger problem with the cemented implants, but it still exists. That is, the interface between the implant and the bone loosens and can cause some pain. Fracture, it can occur as a result of doing the operation, because you're basically putting especially press fit, you're a porous ingrowth, you're putting a stem into like a pipe, and you want to get the tightest fit possible, but not too tight. So there's obviously a learning curve with that. Or you can fracture afterwards. Nerve damage, very uncommon. There's a small percentage of any operation where we do everything perfectly. X-rays look great, the incision looks great, people still have some residual pain. That may be because the pain they had wasn't coming from the hip in the first place, or they may have neuroma, they may have something else going on. But one of the complications that's kind of unique to orthopedic surgery, not unique, but DVT, which is a deep venous thrombosis, or a PE, pulmonary embolism, is a blood clot. If you don't have any anticoagulation, you have about a 30 to 40% chance of having a blood clots. They can break off to your lungs. Worst case scenario, they can kill you. The standard of care in the world really is if you have a total hip or total knee, you are put on some type of anticoagulant for a month. We use aspirin, usually baby aspirin twice a day. If you have some medical reason why you're at higher risk, your surgical doctor, your surgeon or your medical doctor may want you on something a little bit stronger like Lovenox or Xarelto or warfarin. As a surgeon, we want as little bleeding as possible. The medical people want the blood as thin as possible. Obviously, we have to compromise. We don't want our patients to have blood clots, and they don't want our patients to bleed into their wounds and have hematomas. But that's why most orthopedic surgeons, if they can, will use aspirin, and it's cut down the risk of blood clots significantly. And then there's anesthetic complications. Well, again, a small number of people given general anesthesia, less so with spinal. I mean, there's a fatality rate with any operation. It's incredibly small with elective total joint replacement, probably 1 in 500,000. But other anesthetic complications, a situation where if you're getting a spinal, the spinal lasts longer, and you end up not having good muscle control of the leg for a day or two. And that's a problem if you're planning on going home the same day. I've done several hundred outpatient total joints. I had one that I had to send to the hospital overnight because his spinal lasted longer than it should. I sent him for physical therapy. By the time the therapist got around to seeing him the next day, he was already up walking around. So it was just a place to put him because we don't keep people overnight in a surgical center. But basically, they're very rare and generally treated. So these are some old complications. We don't see these very often anymore. The metal stem, if it's well fixed here, anything that's not organic will get weaker over time. So if you get a piece of metal and you bend it back and forth 5,000 times, 5 million times, 50 million times, at some point it will get fatigue and break. That's why we don't use steel implants. We use titanium or cobalt chrome because they're much more resistant to fatigue. And I, knock on wood, have not seen one of these in my entire career. I did as a resident. The older implants, the older fixation, you actually get failure of the implant, or you can get failure, you have a fracture around the stem, which can occur. And again, these are fairly uncommon now, but still can theoretically occur. Periprosthetic fracture. So you have the operation, you're doing great. But you have an interface between the metal, which has got a very high, for the engineers out there, modulus of elasticity or stiffness, and then bone, which is a lot softer and more flexible. And anytime you have an interface between something that's stiff and not so stiff, it creates what's called a stress riser, where if something's going to break, that's where it breaks. And so sometimes patients have total hip replacements, and I think this happened to Bo Jackson. The geniuses that did him forgot that even though he was Bo Jackson, the basic laws of physics still applied. They let him go out and play baseball again, and this is what happened to him. So you need to modify your activity after a hip replacement. We're not talking about sitting home and crocheting, but there are certain things that you may not want to do. Probably rugby, not a good sport for somebody who has a total hip replacement. Okay, what are the complications? What are the things that you can do to increase your likelihood of doing well? So some of these things you can't control. If you've had previous surgery, you've had previous surgery. If you've had a previous infection in the area, that's past tense. They do increase your risk of a complication. You can, to some degree, control obesity, though. And again, the studies show the complication rate is astronomical if your BMI is over 50, and it's much higher if your BMI is over 40. And just for purposes of discussion, if you are 5'10", and you weigh 300 pounds, that's a BMI of 43. So you're just barely over it. So we're not talking about asking people to come in, ready for Victoria's Secret catalog covers. You can't be 100 pounds overweight. It substantially increases your risk. Diabetes. Obviously, having diabetes increases your risk, but There's a thing, and if you're diabetic, you would obviously know this, called hemoglobin A1C. It's a measure of the control of the diabetes, and we will insist that your hemoglobin A1C be below 7.5 or you get cancer. Poor nutritional status. So it's kind of a catch-22 here, okay? We tell you to lose weight so you don't need anything, and now you know. We don't want people starving to have their surgery. You want to make sure that your albumin, which is a protein that is in your body, so you want to make sure that what calories you're getting are nutritional calories. And then the other thing is cigarette or drug use. Smoking, bad for wound healing. We're not the police, but if your insurance company knows that you're smoking cigarettes, they want to prove your total hip or total knee. And there's a reason for it. Now, part of their reason is they don't want to pay for the joints, but the risk of a complication is high, and the expense of a complication of one of these operations is pretty significant. So you really want to do everything that you can to minimize your risk of having a complication. So again, just to kind of summarize, combination of better surgical techniques, the incisions are a lot smaller, the implant technology has gotten better, anesthesia has gotten better, our physical therapy regimens, which I didn't go into, but we're big on getting people to therapy, you know, show them the exercises beforehand, have resulted in much quicker recovery, less pain, and improved long-term function. To the point where we, myself and the guys in our group, doctors in our group, I should say, you know, female physicians as well, operate out of several hospitals, University of Penn, Princeton, Robert Wood Johnson Hamilton, Capital Health, St. Mary Medical Center, and some of the guys go to Area Jefferson. And we have our own surgical center as well that we own part of. And we've gotten to the point where myself and a couple of the guys who do a lot of joint replacements can do healthier patients as an outpatient. Literally, you come in at 7 in the morning and you go home at 1 o'clock in the afternoon. It's kind of almost like a concierge service. It's theoretically safer because no one that's ever been there has an infection. I mean, if you've had a previous infection, you can't go there. We know that way. You get the physical therapist is literally sitting around waiting for you to be ready, as opposed to a facility where you kind of get in line. And the insurance companies like it because it's less expensive. So if you're younger and healthier, this is probably a great option. This is where the government and the insurance companies are kind of pushing us to go. But if you're an appropriate candidate, and that's a big if, it's a great place to go. But the reason I put this slide up is we can get people out. If you had told me as a resident that we'd be doing total hips as outpatients, I would have thought that was a ridiculous thought. So it really does represent an improvement. So under optimal circumstances, we like to think that a joint replacement can last up to 30 years with normal use. You need, of course, to have realistic expectations. So these are unrealistic expectations, okay? If somebody comes to me and they say, I need a hip replacement, I like to run a marathon, it's like, pick which one you want. We don't want you doing a lot of repetitive impact loading on a joint. It's going to increase the rate of failure. And people think, well, that's no big deal. I'll just have it revised. Yes, we can revise joints. It's not the same thing as the first time around. You really want to get it right once and make it a one and done type of deal. So this type of activity, not something you want to do. Bike riding, swimming, golf, maybe pickleball. Those are things you can do. Can you run across the street? Yes. But I mean, I have a friend that plays lacrosse once a year with his hip replacement. Not my advice, but should you? The answer is no. So what we call normal activities of daily living, low demand exercises are very appropriate. And basically that is the end of my formal talk. I'll just one or two things that I think I may not mention. One question that I hear all the time is, when do I know if I need to have a hip replacement? And the short answer is, if you're not sure you need a hip replacement, you probably don't need one. But there are a few circumstances where a surgeon will tell a patient, you really should have the hip replacement. So here's a normal hip, okay? There's a thing called protrusio, where the hip actually starts to erode into the pelvis. And this kind of eats into it like that. And I will tell somebody under those circumstances, if you don't do this surgery now, it's going to be much harder to do and you're going to end up with a much poorer result later, okay? The other time would be if somebody is starting to get a real bad deformity where the contour of the cup is getting to be deformed because it's eroding into the bone up this way. Under those circumstances, again, it's always elected in one sense, but I'm going to tell you, look, if you don't do this now, it's not going to be as good later. Other than that, it's really, how much does this bother you? If you're taking an Advil before you play around the golf and you're otherwise fine, you probably just accept that and move on to the next thing. If during normal activities, if you're going to the mall, you know, you're going to see your grandkids and you don't do this or that because your hip hurts, well, that's when you should have the surgery. Okay, good. Let's just see what we got here. Do these hip injuries cause any pain down the leg? Kind of like radiculopathy. As a general rule of thumb, hip pain can cause pain into the knee. It almost never causes pain below the knee. It can cause pain into the thigh or knee because the obturator nerve, which is near the hip, goes down to the inside part of the thigh. So if somebody has pain going down the back of the leg or going below the knee, pretty much going to look for some other reason besides a hip problem to explain that pain. Let's see, I had pain on the outside of my hip area and was told if the pain is on the outside of the hip, it is usually related to the back problem, not a hip problem. Well, there's a rule in answering multiple choice questions, and always and never are usually not the right answer. And this is certainly the case. Certainly on the outside part of the hip, you can have a trochanteric bursitis. That's a hip problem. That's where you put your hand by your pocket. Sometimes hip arthritis hurts in the back and the buttocks area. So if somebody has, this is not that uncommon, they have symptoms and they have problems with their hip and their problems with their back, and you're not sure, well, which is this coming from? And sometimes it can be a little bit of both. One of the things we can sometimes do is a diagnostic injection of lidocaine and cortisone into the hip under ultrasound to see how the person does. Now, that's not going to give them a long-term result, but if they get better for a month, then you know, okay, it's the hip, and then you can go from there. What's the general recovery time for a repair of a labral tear in a 30-year-old? I'm going to say it depends on what you're talking about recovery, but I'm pretty sure you're not going to be doing much inside of 3 months. Again, it depends on the specifics. If they do a debridement of a labrum, it's much quicker. If they actually go in and sew the labrum back and it has to heal, it's going to be 3 months. What's the upper limit of Advil's 190-pound male should be taking? Well, so Advil's over the counter. I'm not sure what they say on the label, but Advil comes in 200 milligrams. The prescription strength of ibuprofen or Motrin is 600 to 800 milligrams, and it can be given 3 to 4 times a day. I think the most you really want to take is 2,400 milligrams, and that would be theoretically 24 divided by 2. That'd be 12 Advil in a day. I don't think you should be taking 12 Advil in the day without some medical supervision. And you need to be careful you don't take it that long. I think it's reasonable to take 2 Advil 3 times a day. That's what I tell my patients. If they need something other than that, I put them on a prescription. And if they're going to be doing it long term, I make sure either I or their medical doctor checks their blood levels once in a while. So that, what's the sign of a total hip is failing? Well, usually pain. So somebody comes in and they say, well, I was doing great and now I'm not. Now it hurts when I do this or that. Or my hip popped out of place. That's obviously a sign. But the most common one is pain in the groin or in the thigh that occurs. Let's say somebody's had hip replacement that was done 15 years ago and they're doing fine, and then they start to get pain in the groin. You do an x-ray and you see there's some loosening, that type of thing. So it's usually pain. It can be a shortening of the leg that occurs after the surgery if the implant is kind of subsiding or sinking into the bone. That's one of the things that happens with uncemented ones occasionally. But it's rare that you're going to be having a problem that you wouldn't know about. What's recovery period for hip replacements? It depends on what you're calling hip replacement, recovery rather. I've had a guy came back to his appointment on a motorcycle, not something I would recommend. Generally, I tell people are generally out of work for anywhere from 2 weeks to 3 months. If you're an HVAC contractor, you're going to be on the 3-month side of things. If you're in really good shape and you have a white collar job, you could go back to work in a couple of weeks. Used to be the textbook said no driving for 6 weeks. I've sent people back to driving in 2 weeks. That has to do with the hip precautions. You don't want to bring your hip up way high. A lot of it depends on the condition of the individual. A 50-year-old that's in great shape that has hip arthritis is different from somebody who's 75 and overweight and has had problems for a long time. This is a patient that had before a hip replacement, had an injectional lidocaine, depomedrol. Oh, how long would you inject? Well, I'm not sure what the question is. I want to answer two different questions. How long does the injection last? It can last a couple months. The medicine's in your system for a couple days or a week. That's something you do before surgery. If you have an injection of cortisone or anything into your hip, and in order to get it into the hip joint itself, you need to do it under X-ray ultrasound. You can't do it in the office. That means you cannot have a hip replacement for 3 months. The risk of an infection is higher if you do it inside of that time frame. And as far as doing an injection after a hip replacement, if you're talking about injecting near where the pocket is, the trochanteric bursa, that's something you do. I don't want to hear about any of my patients having hip injections into their hip joint if they have a total hip. Number one, it's not going to do any good. Number two, they're begging for an infection. So, I would never allow that, and I get very upset when I see some other doctor does that. What do you do with a hip that's bone on bone and a lot of pain? Well, that's when you do a hip replacement. Well, again, we generally start with conservative treatment no matter what. There are times when we see somebody and we know, look, this is not going to work, but at least try this, that, and the other thing. It's good to try, number one, and number two, it makes the insurance companies happy. They don't want to see that we just saw somebody and said, here, go have a hip replacement. But in general, there's no absolute correlation, but if you're bone on bone and you're having a lot of pain, the likelihood of, if you take Advil or Aleve and it works, that's great. But if it doesn't, and you're having a lot of pain, the definitive treatment is probably going to be a hip replacement.
Okay, Dr. Nolan, I think you've answered all of the questions. So again, thank you for taking your time to educate all of us on hip pain. If anyone would like to schedule an appointment with Dr. Nolan, you can go to our website at www.mbortho.com and use our online appointment request form, or you can call 855-896-044 and go through our scheduling department. If you have any specific questions after this presentation, please feel free to give me an email at programs@mbortho.com. I will be sure to consult with Dr. Nolan and get back to you with any questions you may have. I just wanted to thank everyone again for sharing your time with us this afternoon, and we look forward to seeing you again soon. Thanks.